the Vice Minister for Health Services and Health Insurance. She's an economist with a master's in public administration in international development from Harvard Kennedy School. Prior to joining the Ministry of Health in Peru, she worked in the Ministry of Planning and Development of Ecuador in the Apoyo Consultoría, a leading consulting firm also in Peru. So we are really, really happy to have you, Cristina. Please.
Thank you very much for the opportunity to share with you how we're thinking primary care in Peru. Peru is Peru is an upper middle country in South America. Our health spending is low compared to international standards and also among the lowest in the region. With like 5.5% of GDP, which is half of OECD spending. But the problem is not that only we don't have that many resources, but we're not using the little resources that we do have in an efficient way. And with the ministry's main goal of achieving universal health coverage in the country, stepping stone to that ambitious goal for us is to improve efficiency within the system. And we have started by rethinking primary care because our primary care facilities are not giving a quality care. This is a picture of how people are waiting outside our facilities right now, starting as early as 2 or 3 in the morning to get a 15-minute consultation that will happen like 9 or 8 hours after they started making the line. So firstly, our facilities are overcrowded, are understaffed, are understocked, have outdated equipment, and are in bad conditions. Secondly, we found our facilities are geographically redundant, which means that we have facilities that are like 5 minutes away from each other. And this redundancy depletes the resources that we have because we have to maintain more facilities than our patients need. And this means more human resources, more complicated logistics, and more administrative procedures. And finally, our system is hospital-based. So people auto-refer themselves to the hospitals for conditions that could be easily treated at the primary level. And 2 examples of this. 45 of the consultations in hospitals do not require a specialist, and 60% of the emergencies are low priority. These 2 could be easily solved at a lower level facility. And so our goal is to make important changes in how primary care works and how we're doing this. We're implementing 2 types of primary care facilities that would efficiently interact with hospitals when needed. So the first type is a family clinic with primary care practitioners that will expand their service hours from the current 4 to 12 hours. And the second type are urgency centers that will work for 24 hours with the capacity of solving low priority emergencies. In these facilities, we're doing a series of interventions that include reshaping patient flows within the facility so that they're more patient-friendly. We're implementing demand control tools such as online and phone appointments. We're implementing EMR technology, and we're building the capacity in terms of soft and hard skills so that our staff at these facilities provide a service that is based on what the patient needs. And the project we're piloting is based on a patient-centric model. We started in a densely populated area in Lima, where we selected 7 facilities out of 20 in the area to target a population of around 250,000. And with these 7 improved facilities, we plan to increase the number of consultations and procedures by 30%. We have started a 6-month pilot. We're halfway through. And if you remember the picture I showed you before, this was the line before, and this is the line that we have here. So we already have some results. And the objective is to scale up, but we need to first have clear signals for the Ministry of Finance that we can have a public system that is working and a public system that could improve quality of care. So going to the start of my presentation, this is a necessary stepping stone to leverage the financing that we need for this broader goal that we have, which is universal health coverage. Thank you.
Thank you, Cristina. We heard yesterday that quality and efficiency go together, and that cutting funds is not a way to force efficiency, but actually may create inefficiency, so that your efficiency should be manifested in quality, which is what people really demand. Thank you. We also know it's not easy to do these changes because there are so many players in the system already. And one of the paradoxes of universal health coverage is the early you reorganize your system, the better. Because once you wait till you reach upper income levels, the vested interests are so high. So paradoxically, a poorer country has a better chance to organize their system than a richer one like the United States. And a second presenter from Argentina, we have Professor Adolfo Rubenstein. He is the Secretary of Health Promotion, Prevention, and Control of the Argentine Ministry of Health. He's also a physician, a professor. We met actually as internists 20 years ago. He's a professor of public health at the University of Buenos Aires. He has a master's in clinical epidemiology from Harvard. He has a doctorate in public health from UBA and a diploma in